The topic of discussion is reflux esophagitis, and under that topic we'll be talking about Barrett's esophagus, right? That will fall under GERD, right? Gastric reflux, gastroesophageal reflux disease, right? Okay. Now, what are the things that we'll be discussing in this? We'll be discussing about all these notes, all these diagrams, and after completing these, right, we will be correlating these topics with the content present in Robbins, right? We'll be correlating with all these things. As you can see here, we have got Barrett's esophagus topic, right? Okay, now without delay, now let's move directly into our topic. So okay, now before beginning with it, right, okay, now what is reflux esophagitis, right? What is reflux esophagitis? Okay, simply reflux of gastric content, right? This is a definition mentioned in Robbins. Reflux of gastric content into lower esophagus is most frequently cause of esophagitis, as we have already talked in earlier esophagus applied anatomy. In that we talked about what lower esophageal sphincter, right? Lower esophageal sphincter. This lower esophageal sphincter is what is this? At the time of its high functioning, it will prevent what it will do is it will allow food material to fall to go in one direction, but at the time in which it will be not functioning well, what it will do is it will just reflux the content of gastric, right, toward esophagus. So reflux of gastric content into lower esophagus is the most frequent cause of esophagitis. Yes, we talked about that thing, and most common outpatient GI diagnosis in United States. Okay, and the associated clinical condition termed gastroesophageal reflux disease, right? Gastroesophageal reflux disease, right? Gastroesophageal GERD occur because of esophageal epithelium, because esophageal epithelium is sensitive to acid despite being resistant to abrasive injury. Okay, what he's saying is that we have esophagus, and this esophagus consists at the distal point. What we have is we have lower esophageal sphincter, and this lower esophageal sphincter, what it will do is what is going on is this lower esophageal sphincter will it will just cause reflux of gastric content into esophagus, and gastric content, it is rich in HCl. As it will go up, what will happen? These epithelium of esophagus, these are acid sensitive, so these HCl will cause what? It will cause inflammation in esophagus, and that is what we call what? Esophagitis, right? Esophagitis. That's all. Now moving further, what we have is, okay, let's talk about what reflux esophagitis. Yes, we are discussing about that thing. The most common cause, right, the most risk factor of reflux esophagitis is transient lower esophageal sphincter. Yes, we're talking about that thing only, right? It's relaxation, right? TLESR. It is the most risk factor, right? And other risk factor include smoking, alcohol, obesity, overeating, pregnancy, hiatal hernia, right? Hiatal hernia. We have caffeine also, right? Caffeine is also main risk factor, right? We have chocolates. Okay, now okay, talking about clinical feature, right? What is going on here is there will be retroesternal pain. Okay, retroesternal pain, there will be burning sensation. And if you recall the fact, right, that we discussed earlier, that retroesternal pain is also a clinical feature of MI, myocardial infarction. But at that time, what will happen is this at the time of myocardial infarction, there will be excusing pain, right? Excusing pain. But in the case of our GERD, reflux esophagitis, there is just retroesternal pain only. Okay, now we will find sour breath, right, because of HCl being refluxed out. We will find teeth discoloration, right, because of acidic content. Now yes, but we are under the topic of what? We are on the topic of reflux esophagitis, right? Reflux esophagitis, and that is similar, or we can just take parallelly these. We can take reflux esophagitis parallelly with gastroesophageal reflux disease also. Okay, now how will diagnose reflux esophagitis? We'll diagnose is by studying the 24-hour pH, right? 24-hour pH of esophagus, right? We can also see the pressure difference, right? We can see the pressure difference. That is what we'll do with the help of manometry, right? There will be less pressure in the case of lower esophageal sphincter, right? Because of the less pressure within this lower esophageal sphincter, what is going on? It will not just perform the unidirectional movement of food content. It will just cause reflux of gastric content. Okay, and another thing that we can do is we can do endoscopy, or we can do biopsy also, and that will be the confirmatory diagnosis test, right? Confirmatory diagnosis test. Okay, this was just brief about brief introduction about our reflux esophagitis. Now moving into what we'll be moving into the complication because of reflux esophagitis, GERD, and that is what we call Barrett's esophagus. Now what will happen at the time of Barrett's esophagus? Okay, now at the time of Barrett's esophagus, what will happen is, as we have said, what is this? This is our this is, okay, here we have, this is our esophagus, right? And here at this point we have we have lower esophageal sphincter, right? And there will be, because of less pressure within this lower esophageal sphincter, what will happen, that the gastric content will just move out, right? Gastric content will just move upward. And as we have mentioned already, these esophagus are acid sensitive, and since they are acid sensitive, what will happen, that these esophagus, which are normally covered by stratified squamous epithelium, right? Normally the stratified squamous epithelium covers our esophagus, right? Now what will happen, because of reflux of acid content, these stratified squamous epithelium, they will be converted to intestinal columnar epithelium, right? Now what are these intestinal columnar epithelium? Okay, if you recall the fact, then intestine consists of simple columnar epithelium, right? Simple columnar epithelium. Okay, now what is going on here is, here the stratified squamous, they are being converted into intestinal columnar epithelium. Okay, we are not saying simple columnar epithelium, we are saying intestinal columnar epithelium. We are saying intestinal columnar epithelium because here the columnar epithelium consist of here the columnar epithelium consists of goblet cells, or we can say the intestinal columnar epithelium are different from simple columnar epithelium in presence of containing in presence of goblet cells. Okay, now here, since this is this is the transformation of one epithelium into another epithelium, it is called metaplasia, right? Metaplasia. Okay, you can see right here, what is this? This is our stomach, right? Gastric region, and here you will see esophagus. What is going on here? You'll see here it is written Barrett's esophagus. That means you'll see the upper region, right, where there is no effect of gastric content being pulled up. The upper region is stratified squamous, but below than that, right, till the area where there is effect of acid, we'll find intestinal columnar epithelium. Now here there will be the presence of goblet cells. That's all. Now here, right, if you see this picture, what you'll see is, in healthy, right, non-Barrett's esophagus condition, you will see you will see this normal, right, normal looking mucosa, right? But in the case of unhealthy, right, individual with Barrett's esophagus, what you will see is, you will see a red velvety mucosa, right? You will see red velvety mucosa, as you can see right here. It will be clear in other diagram also, right? And that is one important point. Okay, Barrett's esophagus, okay, it is intestinal metaplasia, right? And it will, when it get worsened, right, as it will get worsened because of inflammation, it can be it can also cause the damage to cells, that is dysphagia, right? And ultimately it is most common risk factor for causing adenocarcinoma of lower part of esophagus. Why lower part of esophagus? Because this lower part of esophagus is what we have the most, what we have in contact with our gastric content. Now how we'll manage this Barrett's esophagus? Okay, before managing, okay, I would like to take you toward another thing, and it is same thing. Barrett's esophagus is a metaplasia in which stratified squamous epithelium, right, it will be converted to columnar epithelium. Talking about specifically, it will be converted into intestinal columnar epithelium that consists of goblet cells, right? Now it is columnar lined esophagus. Now it will be columnar lined esophagus. Okay, right? Okay, now yes, columnar lined esophagus is what is our Barrett's esophagus. It is of two type. One is short segment, right, that will be less than 3 centimeters. One will be long segment that will be greater than 3 centimeter. The short segment one has a less chance of developing into adenocarcinoma, but this long segment one, it has a high risk of developing into adenocarcinoma. Okay, as you can see right here, the risk factor, right, gross red velvety granular mucosa. Yes, we have seen these things right here, right, red velvety granular mucosa, right? Okay, yes, histologically what we'll find intestinal metaplasia, we'll find goblet cells. Right here you can see, right here, if you'll see, this is a normal individual, right, normal individual. This is a normal esophageal squamous mucosa. Right here you'll find normal mucosa, right, normal mucosa, and that is what stratified squamous epithelium, right, stratified squamous epithelium. Right now, okay, now these here we have stratified squamous epithelium, and then we have what, submucosa, right, that goes like this. But in the case of Barrett's esophagus, what will happen is, you will see, what you will see columnar cells, right, with the goblet cells right here you can see. And this is what, okay, here in this area, this is what, this is normal individual, right, without Barrett's esophagus. Here this mucosa, it consists of what, it consists of stratified squamous epithelium, right. But here in this region, what you will see is, you will see what, you will see columnar cells with goblet cells. Right now, what, yes, this is the area of Barrett's esophagus, right here, where we have intestinal intestinal epithelium, right, intestinal columnar epithelium. Right, why intestinal columnar epithelium? Because it consists of goblet cells. That's all. Okay, now moving further, okay, you can see, okay, what is the function of goblet cells? The function of goblet cells is that it contain mucin, right, it consists of mucin, and these mucin, right, these mucin are stained by Alcian blue, right, Alcian blue, and that is how we will distinguish, what we will distinguish, or we will find out our goblet cells. Okay, in this diagram you can see the circled structure, right. What are these? These are what, these are goblet cells, right, these are goblet cells. You can see right here, these are goblet cells, and these goblet cells secrete mucin, right, these secrete mucin, and these mucin are what, stained by Alcian blue, right, and with the help of these stained Alcian blue, we can confirm that these are goblet cells. Or it is also mentioned right here in this okay, in this diagram, if you will see carefully, you will find blue structure. What are these blue structure? These are Alcian blue, right, these are Alcian blue. Why they are blue? Because they are blue because here they are staining what, mucin, right, mucin. Now what is now how did this mucin came from? It came from goblet cells. It came from what? Goblet cells. So now here, so this is one important diagram in which we will just see goblet cells which are visible as stain of Alcian blue because of mucin. Okay, now moving further, what we have is, okay, we're talking about what, we're talking about management, right. Now to manage Barrett's esophagus, what we can do is, we can decrease the amount of acid being secreted, right, and that can be done with the help of proton pump inhibitor, and that is what we have drug of choice, right. We can just what we can do is, we can use prokinetic drugs also, right, and the most complicated thing is that we can do surgery, right, and that is what we call what, fundoplication, right, we can call, that is what we have, fundoplication, that is what surgery is. Now okay, moving further, what we have is, we have, okay, same thing again, and I will be revising many things. Okay, Barrett's esophagus, right, how we will find out the condition of Barrett's esophagus is, we can do endoscopy, right. While doing endoscopy, Barrett's esophagus is identified by the presence of reddish mucosa, same thing that we mentioned earlier, right, reddish velvety mucosa, right, reddish mucosa that can be seen in comparison to pale normal mucosa. The normal mucosa is paler in structure, but here we will find red velvety mucosa, or we can just see here also, right, these area, these red velvety, right, red, these are what, these are these are mucosa, red mucosa of Barrett's esophagus, right. That is how, what we will see endoscopically, holding endoscopy. But while doing microscopically, right, normally esophagus is lined by stratified squamous epithelium. Yes, we knew it earlier. In Barrett's esophagus, what will happen? This stratified squamous epithelium will be gradually replaced by intestinal columnar epithelium. Important fact about intestinal columnar epithelium is, it consists of goblet cells, right. And here since there is change in nature of epithelium, it is called metaplasia, right. Okay, if this condition persists for a longer time, then there will be the high chance of adenocarcinoma of esophagus. That's all. Now here, the adenocarcinoma of esophagus is mainly this will mainly occur in where? where in the lower one third of esophagus, because it is more exposure to acid reflux. Okay, in order to identification, right, of microscopical identification, we can see goblet cells, right? We can see goblet cells with the help of mucin, right? And these mucins were stained with the help of stains called LCN blue, right? We mentioned it earlier already, right? Here, okay, this diagram also we discussed it. This is the normal individual without Barrett's esophagus, but here what you can see is we can see columnar cells right here, right? You can see columnar cells right here because of what? Because of metaplasia. And that's all. We studied about this diagram, we studied about this diagram. Now moving toward the content of what? First aid. Gastroesophageal reflux disease. What is this? It is presented with heartburn, yes, regurgitation, dysphagia, right, and may be also presented chronic cough, hoarseness, laryngopharyngeal reflux associated with asthma, right, transient decrease in what? Lesser esophageal sphincter tone, right? Talking about Barrett's esophagus, what is this? It is specialized intestinal metaplasia, right, replacement of non-keratinized stratified squamous epithelium with intestinal epithelium, right? And here these intestinal epithelium are non-ciliated columnar with goblet cells, important one, right? Okay, you can see right here. Okay, due to chronic gastroesophageal reflux disease, GRD, associated with the risk of esophageal adenocarcinoma. Yes, we know that thing. So I think we are clear about all the things that are written right here. Now just for what? Correlation, will move toward what? Will move toward our Robbins. Now here in Robbins, what we have is we can see reflux esophagus, right? Here we have definition of reflux esophagus as we have mentioned earlier, right? The lower esophageal esophageal sphincter will not work properly, and that will cause what? Reflux of our gastric content. And pathogenesis, yes, same thing is written right here, right? And it has written about the what? Because of it is mentioning about what? Different cause such as alcohol, tobacco, obesity, and these all things, right? Now here it is talking about morphology, and talking about morphology, it is written hyperemia, and this is what? Hyperemia is excessive blood supplying an organ, right? Okay, now here we have what? It is mentioning about Gerd, gastroesophageal reflux disease, right? Okay, these are the structures. Now moving further, yes, here it is written about what? Clinical feature and the way of management, right? And we'll find in endoscopic biopsy what we'll find. It is written right here. It is writing about hiatal hernia, right? Risk factors. This is the brief introduction, and here we have detail about Barrett's esophagus. Same thing are written right here, right? Okay, here you can see what is this? This is our gastric, right, linings, and here we have esophageal linings, right? But this is the normal individual, but here what is going on is this esophageal lining also they are containing what? They are containing columnar epithelium, right? You can see there is similarity, a bit similarity here in this case, right? This is what we discussed, right? We discussed about morphology, right? Tongue of red velvety mucus exiting upward from gastroesophageal junction, right? Okay, we talked about what? We talked about our long segments, and we talked about what? We talked about another short one, right? Shorter segment one, and yes, we said that shorter one has less chance of developing into adenocarcinoma, but longer one has a higher chance, right? Okay, other things, yes, we talked about diagnosis, how to diagnose it, right? Through endoscopic, and also we can see what? Goblet cells, right? Play blue color because of what? Because of our LCN stain, right? It will if the condition what? Become worse, then it may result dyspnea, dysplasia, right? And it can just cause what? It can cause adenocarcinoma, right? These are the thing. Okay, these are the things that if you'll go thoroughly, just will be able to what? Will be able to understand each and everything. So this much for our what? This much for our reflux esophagitis and Barrett's esophagus. Thank you and have a great time.